So, Dr. Brendon Dellar, thank you for meeting me for this episode on ThreeBestRated. So what drives really the mission of Cygnet Clinic?
Well, our mission of excellence in psychological health really came out of the early establishment of Cygnet. Like, we really wanted to establish a service that from university, students could graduate and have a really well-supported registrarship, which is sort of like the training you do after you graduate. And at that time, there wasn't a lot of clinics available to do sort of the postgraduate training. So there was a gap there, and a lot of students really required or requested a lot of extra support. So we established ourselves as a training clinic and brought in the best sort of people we could find. And a lot of these people are still with us now as clinicians, but were senior supervisors in the public sector, in NGO. So we built this model of university research, what's contemporary and cutting edge and advanced in terms of treatment and psychotherapy, and how we could implement that in a clinic that had links to university, so we're always up to date. So the whole focus on excellence is really looking at not us as just being self-branded excellent clinicians. It wasn't about that at all. It was about having excellence in terms of our research, bridging to what we were doing. So that was our mission statement, was to allow students to learn and get the best people to teach them. So that was the conduit to the actual value of just pursuit of excellence.
Excellent. And what key factors do you think actually helped Cygnet grow into this big multidisciplinary clinic that it is today?
That's a really good question, because I've thought about this quite a bit, and I think it has to do with, quite paradoxically, what I can't do. So it started off with me as a sole practitioner in a very busy general practice, and I was getting referrals for things that psychologists often would accept, but I felt a little outside my comfort zone in terms of my expertise. So we had a model which I sort of cleanly profiled 5 areas of interest that people who join the clinic as clinicians are passionate about. So, for example, we've got Melanie Brown with us now, who her area is perimenopause and menopause and the psychological emotional difficulties that go with that transition. So we made the list quite narrow, and by doing that, we actually attracted more referrals because people knew exactly who, say, Melanie was, and that what she did was quite specific, or myself with addictions and trauma. If they had an addictions patient they want to refer, that would be quite simple. So it grew by having less, and it retained the staff as well, because we were doing what we love doing. Mm. And that list is dynamic. So it's not like it stays the same for decades. You learn new things and you change your interests as time goes on. So it helped grow the clinic because people didn't want to leave because they were doing what they loved. And if they didn't love what they were doing, well, we provided training so that they kind of got opportunities to learn new things. So it worked in an organic way. It wasn't a planned. Our focus was on the work we did rather than any kind of marketing growth. So we very clearly stayed away from that kind of corporate marketing drive, and we just focused on what we do best, which is the clinical work.
And what inspired your strong focus on trauma in your clinical work?
That was, it was a combination of things at the time. So when I first started, I did a PhD in trauma, so that helped. But after finishing the PhD, actually waiting for it to come through, I went through some lived experience events that were quite traumatic. And I think at that point, it really made me think about where I wanted to go next. And I had in my mind that I'd be an academic and I'd just be doing research and lecturing, which I love doing. But at that juncture, I thought I could use my experience, both personally and professionally, in a way that not a lot of people I knew could. And that was really important for me to do. So my area interest hasn't changed since then. Focused.
And how do you treat clients with both addiction and underlying mental health conditions? What are the sort of early warning signs you see in addictions that people shouldn't ignore?
Well, there's a couple of questions in that one, isn't there? Because I always think of addictions as being a symptom of something else. So I don't think people willingly want to have an addiction. It's not something that is like debt, really. It's not something people want to have. And the more they have, or the more addicted they are to something, the more conflicted and distressed they become. So I've always thought of addiction as a symptom of some underlying cause, because there has to be a reason why people are doing that. And to begin with, it might be functional for a little while. So I think the underlying trauma in particular seems to be a fairly common trait. So that could be a bunch of different kinds of diagnoses, but essentially you're dealing with the underlying issue first. So the addictions isn't quite separate for me. It's a symptom that's a maladaptive coping of something else that people are really distressed about.
What is your most important advice for someone who is experiencing trauma but they're unsure where to start?
I think it's really important to start with talking about trauma with people you feel safe with. So often that is family or loved ones, spouses, people you really feel connected emotionally to already. I don't think that seeing a therapist straight away is particularly helpful in the early days, because a lot of people, most of us, over 70%, would have an event in our life that would be traumatic by definition, and could lead to post-traumatic stress disorder. Most of us don't. So I'd be careful not to make it a pathology too early. Like, just, it happens. If we're able to connect with people around us that we know and trust, and we know we're going to be supportive, that's the first step. I think if it goes on, the second bit of that is that you have people around you saying, I can see you're struggling, and how about some professional help? If those people aren't available, I think that means that seeking professional help a bit earlier, when you know you're not functioning because you're not turning up to work, or you're falling behind in studies, or you're having just trouble day to day where you weren't before, are good indicators that we need to seek professional help.
So that care network is really important, the inner circle, in raising that first alarm.
I think so, for those two reasons. I think the first one is that most people just don't need to get professional help from a clinical psychologist with a label like post-traumatic stress disorder when they don't have it yet. So in the early days, I think it's just a matter of normalising what's happened is horrible, but there's people around you that care for you, and if you do have that network, for the majority of people, that is enough. If that network's not available, of course, then we've got a different set of problems. But then you've got people around you that can say, hey, look, this has been going on for a while and we're really worried about you. So you've got a bit of a check and balance going on there.
As both a practitioner and an adjunct associate professor, how do you bridge the gap between academic research and real-world therapy?
I think it gets back to the first question, because I love teaching and I loved university. So I maintained a strong connection with Curtin University. That hadn't changed. And my original trajectory was to be an academic, and I'm kind of glad I didn't go down that path, because these events had steered me into the kind of clinical direction. But I think university's got a really important role to play, and we provide supervision free of charge. Like, I don't think many private practices, I don't know if any area that really do that sort of work. So we don't put profits before people or student learning. And knowing that I've been a student myself for a very long time, you don't have a lot of money for expensive private practice or for supervision that's paid for out of your own earnings when you graduate. So I'm keenly aware and sensitive to those needs. So we've been really careful in making sure that we provide a sort of a free supervision services to the universities as part of our core values. Not for just the people who can afford it. So the universities give me that kind of role of being able to give students a bit of a bridge, I think, when they graduate. We have a student here today, for example, who is from a local university. They appreciate that support because it's familiar, but it's in a clinical setting. It's outside of the university, so it's their first sort of exposure to it all. So the gap is really about my role in teaching some of the clinical units, like assessment, and then seeing it being practiced by students that I can give feedback to. And it's all linked up very tightly, and I think that's one of our strengths.
What recent trends are you seeing in addiction, particularly amongst young, high-performing professionals?
This is quite surprising to me, but it's now hitting the mainstream media. I saw it first in elite sports, but then later in all sorts of high-performing professions. But gambling seems to be, especially over the last, say, 4 years, I think, has been more a focus of the addiction referrals than I've ever got before. So in the early part of my career, there were addictions that were things like alcohol had been around for a very long time. Things like when methamphetamine was on the scene, it was quite chaotic. But the latest trend has been quite different. It's a behaviour, but it seems to be quite pervasive and does damage to people's relationships, to their career, to housing affordabilities. They're spending most of their money on gambling. So that's the real sort of focal point of where addictions are at the moment in the clinical population. So it's been a change, not a drug for the first time. So something quite different but similar in lots of ways too.
Do you think there's any link there between like the cost of living and economic pressures that have sort of the climate that sort of comes under?
I think there's a bunch of things. I think people's use of social media and screen time being an increased kind of just a norm now. But people are spending a lot of time on platforms that are really kind of reinforcing screen usage, whether it be social media platforms or not. And I think there was a smaller step from that to online betting. I think that made the lines a bit blurry. So it was almost gamifying something that they've been doing in a non-addictive kind of capacity at some level, and then they've just switched over and not really even noticed it. That's what surprised me, really, is that I don't think people were quite aware of where that line was, where they started and when they were just online gaming or doing stuff like social media, probably compulsively, and they were aware of that. But the lines between that and the sort of online sports gambling platforms have been a really big driver, I think. Economically too, I mean, people are under a lot of stress, and the idea that you could put $5 in and win, $500,000, it appeals to everybody. So I think that's definitely a factor that's motivating people who are struggling.
Can you talk a little bit about complex cases in your practice and how your approach has made a difference, potentially in cases like trauma?
Trauma, I can speak generally, not really specifically, but a good example of trauma that a lot of people are unaware of is the high rates of chronic pain, physical pain. So Cygnet recruited a pain specialist as well as a psychiatrist. So we have a team approach to more complex cases. So that really helps differentiate us from just a psychology sort of practice. The pain specialist we've got is brilliant, and he approached us because in his practice he didn't have ongoing access to clinical psych, and in the public sector, when he did, he was able to have great results by treating the trauma with a clinical psychologist, and he was treating the pain. And for a lot of these pain conditions. They're very difficult to, they're treatment resistant, they call it. And a lot of the times he said, when I had success, it was often in conjunction with a psychologist. So that was interesting because it got me interested in looking at the trauma and pain from a different angle. And some of the crossover kind of techniques that work for both are very interesting, very cutting edge approaches to it all. But things like PTSD, there are certain things that pain specialists can do that actually help the work we do accelerate, which is quite an exciting area to be in. But the results really are quite speak for themselves. I mean, people are getting through at 3 times the kind of rate we'd expect them to with a multidisciplinary kind of team. Yeah.
Leading into that, can you tell us just a little bit more about your team? What are your upcomings and priorities for Cygnet over the next little while in terms of expansion, training, or other sorts of innovation? Are you building upon this sort of multidisciplinary approach?
We've been approached by addiction medical specialists just a couple of weeks ago, so there's definitely a great synergy between what I do and what they do. So for me, that would be an extra level of wraparound care with a multidisciplinary team. I think it's very hard in private practice to get multidisciplinary teams to work like they could, and I've really made it a deliberate objective of mine to try to get not just kind of a shallow touching base with each of the clinicians, but a real in-depth kind of case management meetings with the clinicians that are involved with one person's care, of course, with their consent. So that approach, I think, is going to grow and develop into a different type of model where we're not just doing things in isolation, and that can be a really big part of a downside of working as a clinical psych, is that you don't often see other professionals. But to have them all in the same place and to have a really strong emphasis on education, so specialists and education providers coming in and giving us professional development kind of updates on certain areas. So we're all learning together in a very kind of structured way, which is great for how I want to see things go. On the supervision front, we've been working on an app actually that came about because I had students who were on their last prac before they were registrars, which is where they graduate, and they were in remote areas like Kununurra up north. So a lot of the supervision was done online, or all of it was. But the kind of paperwork was still stuck in this kind of sort of signing off on bits of paper. So the platform developed from just an easy way for these logbooks to be logged, to make sure that the reflective supervision comments were put in there, that things were compliant, but it also just grew into a free service that I thought anybody could sign up to in Australia, a supervisor or a student, and have those basic kind of functions taken care of. So I'm pretty pleased with how that's developed, because as a team, we've been using it internally for a year, and I thought, why not just share this?
So what's the name of that software?
psychedu.au. Not a great name to pronounce, but I'm really pleased with the platform. It's really doing a lot of the things that I think couldn't have been done with that distance to begin with, and spurred on a whole heap of development of collecting resources. So we've got one place where students can learn, collaborate, have online groups that they can share, which take the place of peer supervision groups that traditionally had to be in a physical place. But when you're in remote parts of the state, I mean, it's just not possible. So it addressed some problems that were there, and our dedication to trying to make things free and accessible for students learning has always been a passion of mine. So that was underpinning a lot of the development of that. That's really been quite exciting.
And lastly, what impact has your 3BestRated listing had on your clinical visibility and trust by patients?
A real benefit, and I can think of a few in particular, but one case sticks in mind where I literally think that the value of the Three Best is in its authenticity, because it's not something you go out and purchase. I didn't go and market myself and pay money to be on a directory. So that independence, I think, of you're not just getting a list of the richest people paying to get on there. And we don't do that as a clinic. It's largely not our philosophy. We just try to concentrate on the work, and none of us are trained marketing professionals. So we hope that the work we do is good enough so that people have a good reputation that's organic. So we didn't have a big online presence, but the people I saw trusted the mechanism of having these people rated independently without a financial kind of incentive. So it was a couple of cases, but one in particular was he said it was a lifesaver for him, in his own words, because he was really quite vulnerable at a very low point without that family support, with a lot of difficulties that made it quite risky. I could imagine that, and his faith in the listings was the reason that he saw me. He literally said, I didn't go to any other directory, I just had a look at the Three Best. So that's happened a few times, and every time it's happened, I've registered that this might have gone differently for this individual had they not sought help. In that case, there was no previous engagement with anyone. It was not particularly familiar with mental health services, so it was a big stretch already. So he needed trust and confidence in what he was doing was going to be of value, and luckily it was a good match, and things went really well. So I think it's an invaluable resource as well as a referral.
Dr. Brendon Dellar, thank you very much for joining me today.